Hi Amy, I'm Phil Yazbak from the Neuroscience Group in Neenah, and today I'm going to talk to you about a benign type of brain tumor called a meningioma. Meningiomas are tumors that arise in the meninges, or the lining of the brain. We all have those structures surrounding our brain. As people age, and particularly in women, we can see the growth of these benign brain tumors. We obviously see them in men as well, and we see them in younger people. But as a general rule, the older you are, and if you're female as opposed to male, you would be at a greater risk. By the same token, these are not terribly common tumors, but the thing about them that's interesting is that they tend to be entirely benign, and they tend to be eminently treatable if patients come to surgery in a timely fashion. Because these tumors grow slowly, patients may have symptoms for a long period of time. Those symptoms can run the range from things like headache to weakness, to numbness and tingling, to possibly seizures. If the tumors are located in certain parts of the brain, patients can have personality changes that can often be subtle, and many patients who end up ultimately being diagnosed with meningiomas are diagnosed with mental illness before their tumor diagnosis is made. Example given, depression, because they're, quote, just not right. Typically, the primary care doctor will order a CAT scan or an MRI, and that will prompt referral to either a neurosurgeon like myself or a neurologist, one of my non-operating colleagues. If the patient hasn't had an MRI, we'll then do an MRI, and frequently we'll discuss with the patient our two real treatment options for meningiomas, which are surgery or radiation. Sometimes there's a combination of those two, but typically we start with one or the other. If the tumor is too large for radiation, or if the patient doesn't desire radiation, then typically we're talking about surgery. The next step for a patient with a meningioma would potentially be to have them undergo what's called an angiogram, which is where they inject dye into the blood vessels around the brain, and that will help us determine the blood supply to the tumor. If the patient's going to have surgery, we can then schedule the patient to have an embolization procedure first, where particles are actually shot into the tumor to reduce the blood flow to the tumor and make surgery safer and quicker. Once the surgery is scheduled, and that typically would follow very closely after the embolization procedure, what we would do is set the patient up with another MRI, and that MRI would be used for the purposes of navigation. By taking an MRI and loading it into our computer, and using special equipment we have in the operating room, we can navigate in a similar way to your navigation system in your car and know exactly where to go in terms of making our incision and exactly where to not go in terms of avoiding critical brain structures. The purpose of the surgery is to remove the meningioma entirely, or as much as is safely possible. Sometimes we end up in a situation where we do surgery and we either follow up with radiation immediately or in a delayed fashion, because small amounts of tumor left behind either grow over time, or because the pathology from the original surgery comes back and shows us a rare subtype of meningioma, which is called an atypical, or as an alternative, a malignant meningioma. Typically after surgery, the patients will spend a few days in the hospital with us. If they had significant neurological problems before surgery from the meningioma, they may require rehabilitation. And in terms of follow-up, we typically see the patient 2 weeks after surgery, 6 weeks after surgery, and then we come up with a schedule to follow them over time with follow-up MRI scans. That, in a brief sense, is our overview on meningiomas. This is Phil Yazbak from the Neuroscience Group in Neenah, wishing you all a great day.